national outreach, and now we're going to talk about international collaboration and outreach. And we have a very distinguished panel with us that will set the stage for the discussion. And to me, the discussion is the central part of the session. So I'll ask Dr. Rao to give us the first presentation, and it's titled as Successful Model of Global Collaboration, the How. Dr. Rao.
This one, welcome again. This one?
Yeah.
All the best.
Thank you very much. Congratulations again for the King Khalid Eye Specialist Hospital Group on this journey of wonderful 35 years. When Aziz was with us a couple of months ago, he wanted me to share our experiences of collaboration and how we benefited from collaborations at our institute with partners from different parts of the world. So as I have alluded to in my earlier lecture, this is our model. And I'd like to say every layer of this pyramid that we have created as a structure for our institute's work has benefited from extensive global collaborations. And this is the kind of network we have been able to build over 31 years in the areas of service, education, research, innovation, advocacy, and just about everything. In fact, the very creation of our institute came out of a collaboration. When I was living in America before starting the L.V. Prasad Eye Institute, when the idea of starting an institute came, we formed a foundation in the US called Indo-American Eye Care Society. That, together with our foundation in India, the Hyderabad Eye Institute, were the founders of L.V. Prasad Eye Institute. So that kind of collaboration initiated what we are today. And over the years, we have benefited from partnership with just about every international non-governmental organization in the field of eye care and prevention of blindness in the world. Many major ophthalmic industrial organizations, and of course a lot of individuals who I always say have been generous with one or more of their 3 T's, time or talent or treasure. So with all that, we've been able to grow significantly. Here are some of the names that have helped us in our journey. Each of them have helped in a variety of ways. And first was demonstration of our need for support, whether it is in the form of technical support, guidance, mentoring, monitoring, whatever, or funding. Second was the development of a proper proposal and project and programs that would interest a potential partner to collaborate with us. And of course, there is always a need to create an appropriate team to make any program or project work. A significant commitment from the management of the institute is always a prerequisite for any fruitful collaboration to emerge and the other partner to be happy with what we are, and the kind of enabling environment that one would have in our own organization to attract the collaborators. When all this evolved in our institute over a period of time, it began to create a certain amount of track record, and in the recent past, let's say a decade or so in our 30-year journey, our track record is the one which is attracting increasing number of collaborators in every area of activity that we are involved in. So the support came in the form of technical inputs in the development of various ideas and programs, training our people to have necessary competencies, providing mentoring, even beyond training, and of course monitoring, and many organizations have provided us the necessary funding. A lot of these eventually ended up with very active collaborations. So the impact has been great because of all this. Such active global collaboration was able to produce a significant national impact as well as international impact from our organization. Today we are a 10-segment, functional segment organization. In all these 10 functional segments, we are the beneficiaries of active global collaborations with multiple organizations. And I want to share with you the story of a couple of examples. iBanking, and I know you also struggle with this in Saudi Arabia. When I moved back to India in 1987 to initiate LVP, I went there as a corneal specialist. And everybody told me, forget about corneal transplantation, because the myths were Indians don't donate eyes, corneal transplants don't work in Indian eyes. But in the last 27 years since we started our eye bank, we harvested nearly 85,000 corneas and transplanted nearly 47,000 corneas. We are actually happen to be the biggest corneal transplantation program in the world today. No other institution has performed so many corneal transplants in a country where people believed corneal transplantation was not possible. The reason was because just last year alone, we approached close to 10,000 corneas because we had the right kind of partnerships. In the beginning, I approached the International Federation of Eye Banks, or the Tissue Banks International out of Baltimore. Frederick Griffith, the president then, was very supportive. Frederick was advised by many in the US, many Indians in the US, don't waste your time in India, it's not going to work. But somehow Frederick believed in us, helped us to set up with design of the eye bank, training of our technicians and the team, helped us with the medical standards, and then monitoring and evaluation over the first 5-6 years that resulted in the success of our eye bank over the years. The one single factor that we adopted from the American eye banking system was the hospital cornea retrieval program. This has made all the difference. In a dozen hospitals where we have this program today, the positive consent rate ranges between 65 to 75% when we approach the potential donors. So a lot of other organizations then joined hands to help the growth of this program. So a simple step with an appropriate partner collaborating with Tissue Banks International in the beginning, and then over the years, how we transformed an entire concept into reality and helping thousands of people. This is one example. And another example is our research enterprise. We are quite active research group. Over the past 30 years, we have over 2,300 peer-reviewed publications, 46 PhDs, etc. But all this happened again because of active collaboration and the help that we have received. It started with simple clinical research, prospective and retrospective studies of our own patient, clinical trials, and Brian Holden Vision Institute was responsible for that. In those days, it was called Institute for Eye Research in Australia. They trained our people in the techniques of clinical trials. They gave us the culture of clinical trials. That has helped us to do a number of clinical trials with all the major international corporations in the world. In our institute, one of the things that we did since the beginning is that every clinician has dedicated free time to pursue research. That has helped. This again, I copied from the best practices in American universities, where every clinician also participates in research at the university level. So the clinician-scientist interaction was supported by our institute, and by creating that enabling environment, following or replicating the models, that best practices that we have seen other way, that we have been able to build our research enterprise. And now we have leadership position in all these areas of research, and that is becoming increasingly more and more productive. So a lot of international partnerships around the world, in many parts of the world, Australia, US, Europe, Japan, etc. And that has helped. The third example is most recent one, technology innovation. It all started with a casual conversation with a person from the Media Lab of MIT Media Lab. And out of that came the first hackathon. We invited 100 engineering students for a 1-week workshop. And then that boot camp, in 1 week, these kids produced 21 prototypes. And these prototypes over the years have emerged, and we, in the meantime, started our own innovation center, and that produced that folding phoropter that I have shown you, and the kind of tools that we are able to use in our secondary centers to photograph, and telemedicine tools. And more recently, we have also developed a pediatric perimeter. All this came out of collaboration with MIT. And more recently, many, many other organizations have become partners in our innovation enterprise. And this is going to be a big segment of LV Prasad Institute in the years to come. Again, global collaboration was the key. Education is another example, both faculty training, curriculum development. We train all cadres of eye care professionals, about 500 to 600 people annually in all types of programs. Again, with individuals and organizations, multiple collaboration that helped us to reach where we are in this area. So this overall helped to contribute to the human resource development for delivery of eye care throughout the world. Over 20,000 eye care professionals have been trained through our programs in this area. So these are some of the experiences. So I strongly believe active global collaborations go a long way in helping us to eliminate the problem of blindness and finding solutions, and solutions in a much more accelerated manner. Thank you.
Thank you very much, Nag, and this is a very impressive presentation and experience that you have. And now we're going to hear from Dr. Babar Qureshi, again, another good friend of mine and someone with a huge experience in international ophthalmology, especially in the areas of community ophthalmology and community programs. Dr. Babar.
Dr. Muhammad? Yes, please. Yeah. Almost. Thank you.
Assalamu alaikum and a very good afternoon. Thank you very much, Dr. Aziz, for inviting me to this 35th anniversary, and I am delighted to be here this morning or this afternoon. And when I was asked to talk about this subject, I reflected on this, and I went through the website, the work KKESH has done over the past years. And I thought to myself that this is one of the best kept secrets that are there. And I think that secret needs to go out. Your work needs to be seen, to be acknowledged, and to be recognized. I think a huge amount of work has already gone in, and more is going in. And now you are focusing on the future, and future will always mean change. So I came here this morning with a tie and a suit. Now I am without a tie, with a cap and a badge here. So I've changed over the last 2 hours. That's the speed of change I know Dr. Aziz will want over time. Tomorrow. my talk is more to actually give you some thoughts and to take you towards some kind of a critical thinking of what is it that KKESH should actually be doing internationally, and is that really what you all feel you would need to do? So it's more of questions than answers or directions, but just some few suggestions for you to think about. So the first thing is that you've seen this come up quite often, is the healthcare structure in a country. And it is good to reflect, as I've seen through many presentations, sometimes you see tertiary eye care, sometimes you see centers of excellence. Every level of service delivery has a different role. So the community role has just detection, treatment, referral, and follow-up, followed by medical, surgical, and optical treatment. A tertiary center has teaching, training, research added to a secondary center. But a center of excellence has additional role apart from the other roles it has, and that is to participate in development of policy guidelines and standards, to take part in national programs and national plans, national surveys, and to be able to develop subspecialties. That's the center of excellence that would be there nationally. And then we would like to see what are the different international partnerships that this center can look into. So it's again for you to decide that within a healthcare structure, following what I think should be the different roles, where do you see yourself now and where would you see yourself coming up in future? When we look at international partnerships for a center of excellence, I thought I would look at 4 different major partnerships. One is international organizations. Second was looking at twinning with other institutions. Third was replication of your center internationally. And fourth was research. Now, if we look at international organizations, one of the umbrella organizations is the International Agency for Prevention of Blindness. And the reason I use that is because it has a huge membership which includes donors, it includes service delivery organizations, research organizations. So, and KKESH is a member of the IAPB. This is one of such organizations that if their different skills are mapped, then a collaboration between the two, it's a bilateral collaboration. There are skills that KKESH can give them, and there is skills that they can acquire from such an organization. The second is the World Health Organization. You've so much of excellence in technical knowledge, skills, that there would be a huge amount of input that WHO can get from KKESH, and vice versa. The third organization is the International Council of Ophthalmology, and we have 2 people, Eduardo and Anna from ICO here, and their major contribution to education is there. And since you run a large education program, training program, this could be one of the organizations. So these are the different types of international organizations where memberships are very helpful. They help to improve your own skills and your own profiles. The second is twinning. And the twinning is normally when an institute or KKESH twins with another a similar institution be it in the north, which is the west, or be it in the south, that's in one of the developing countries. And there are many, many advantages of doing that. The first thing is that this allows you a very quick, seamless faculty exchange and faculty development. And this is for both sides. Any collaboration, I always believe, has to be a win-win for all partners. Otherwise, it doesn't work. And then the second thing is that since there's a lot of residency training happening, a residency exchange and skill development is something that would be very good. And the more twinning happens to more institutions, the larger the whole pool of faculty, residence, and exposure becomes. Looking at replication, just I thought that you've been able to establish a huge amount of best practice in clinical ophthalmology and even in the non-clinical sides, patient flows, quality assurance, patient records. All these are huge amount of work that has been achieved, implemented, and tested. And this can be replicated. The whole service delivery component is there, and that can be replicated. And you've got the whole academic structure, academic curricula, accreditation guidelines, and even certification guidelines that can be used and replicated. And this whole replication of KKESH internationally would give you a very different profile than what it is. Research, there are very good, specific, large institutions in the world which excel in research. And whether it's epidemiological or clinical or even basic. And I think such a relationship can only help in ensuring that you start and you begin and you jointly look at very good data, and that data is analyzed to bring in best practices and ensure that decisions are based on evidence. Therefore, finally, what is the impact of such a, how would you see KKESH in future if it did go international? What is the likely impact that it would have? The first is it will enhance your brand. It will increase the profile. People will begin to recognize KKESH internationally. Second is it will widen the horizon of the faculty and resident, and it will develop them as well in terms of skills and knowledge. And finally, it will also provide excellence in research, policy, evidence, and finally leading to change in practice. Ladies and gentlemen, thank you very much for your attention.
Thank you very much, Babar. And the next speaker is Eduardo. And Eduardo is going to talk about technology and the globalization of teaching and training. Very excited to hear that.
This one, technology and
Yeah. Okay, thank you. Okay, hello again. So in the next 15 minutes, I will be talking how technology is affecting globalization of teaching and training, how this can affect us, and how we can benefit from this. So my objectives for this talk are that by the end of it, we'll be able to define what I understand by thinking virtually. how to add value to teaching interventions you already develop to make them outstand, how to cooperate with other hospitals and organizations to spread what you're doing here, and how to engage your potential learners that now are all around the world. So, what do I mean by saying think virtual? Usually in ophthalmology, there are 3 ways we use to train our residents and fellows. 1, in the clinic, 2, in the operating room, and 3, in the lecture room. Since internet came available, many institutions started videotaping these teaching interventions and started posting them on YouTube. But this kind of posting of videos in YouTube has some problems. One of them is the quality of the images you get when you use a camera to record what's going on. And even though you have a great team here in KKESH that has won a lot of awards, there is nothing you can do to do this better if we keep on doing it this way. So what we have to think of is changing not the people, not the team, but the technology and the vision we have of what and why we teach. So when I say think virtual, is that you plan to teach not your residents and fellows in the room, you plan to teach the rest of the world. So for this, you need the software that's been developed for this. Between this, the webinar software that allows for people from any part of the world to attend this. And consider that the room your residents and fellows are sitting in is just another place that's connected to what you're doing. This will allow you to, for example, add a lot of interactivity inside the room and from people connected from outside the room using their cell phones, chatting with the presenter, asking questions, and answering multiple choice questions. The other big advantage of this is that you can bring invited speakers from any part of the world without having to cover their air tickets. Second thing, add value. There are many places you can find good teaching interventions online today. There are dozens of hospitals and dozens of ophthalmic societies producing this. So, if you really want to stand out from all doing this, you need to add value to what you do. There are many ways you can do this. Probably one of the most important ones is to train your experts. Not train them as doctors. Your experts are well trained and do well their work as doctors. But being a good doctor, being a good surgeon, doesn't necessarily make you a good teacher. So teaching is another competency you have to develop in your faculty. They have to learn about adult learning theory to be able to engage, keep attention, and facilitate learning. They need to write goals and objectives, organize the content, develop good assessments. They need to teach differently if they're going to teach facts, concepts, procedures, processes, or principles. And they have to apply multimedia principles that have been learned from cognitive psychology to be able to combine multimedia in a way that it enhances learning effectiveness. This may be difficult, especially with the senior faculty. Not everybody is willing to learn new tricks. But start with your residents and your fellows, because they are going to be your senior faculty several years from now. And in the meanwhile, help your senior faculty that has the knowledge to produce better teaching interventions, supporting them with a group of instructional designers. Abandon this death to being killed by bullets in PowerPoint. Add new technology and new ways of presenting graphics Graphics are there to support what you're saying. It's not supposed that you have to say things and people has to read it on the slide. Focus on creating learning experiences, not teaching experiences. Usually what we do is what I'm doing now. I am standing here, I am talking, you're sitting down passively listening or using your cell phones to answer some emails. So for people really to learn, they have to go through the processing. And for this, they need to incorporate, process, store, retrieve, and luckily be able to apply what they have learned. Synchronous learning is a good thing, but you have the problem that you need the teacher and the learners all at the same time in this virtual room. It has many advantages for interactivity, but you have the problem of the time zones. So if I was giving a lecture at 9 p.m. in Buenos Aires, you would have to get up here at 3 a.m. to listening to it. Probably this will not happen. So this is where asynchronous learning comes in. One of my favorite tools for teaching and having people learn. Asynchronous learning is where any learner can access the teaching content at any time from any place, and they don't need the teacher there because the teaching intervention is stored. This gives them the opportunity to look at lectures that are well structured, that have menus, that they can jump from one part to the other as they need it. They can interact with the lecture, they can answer questions, they can get quizzes, and even they can have asynchronous discussions using discussion forums. Another way of adding value is helping your learners fight the forgetting curve. If you think of it, when you start a learning intervention, what your learners, what they know goes up as the learning intervention peaks, but when it finishes, they start forgetting. And if they don't put into practice this immediately, probably when the next patient comes in, they will have forgotten this. So you have to find ways to fight this forgetting curve and add to your teaching interventions what are called support documents. This may look something like mind maps, as spreadsheets, things that will help them really recall what they learned when they did this intervention. Next thing to outstand is to give rewards. What rewards can you give? Certificates. Certificates that are valuable for your learners. Almost every country has now recertification, and people have to prove they've done X or Y and gain CME credits. So give certificates, and if possible, be accredited by an organization that would ensure that the CME credits you give are good in any part of the world. Focus on the navigation and the capability of searching your teaching website. Make it easy to navigate. Don't be like these two pictures here, where nobody knows where to go and where to find what. Separate your website, your institutional website, from your teaching website. Link them, but have your learners go to your teaching site and find everything they need there. The next point is cooperate with others. Everyone today wants a piece of the e-learning pie. So use some strategies others use. Co-branding. Coca-Cola, McDonald's, and Heinz that makes the ketchup, they work together and benefit from each other, working together. You can do the same with other hospitals and with organizations. Be ready to share what you create. Even if you are doing all the work, co-branding with others will give you more exposure in the rest of the world. Also, you do not have to create everything. Do what museums do, curate. Find good teaching interventions in other places and link to them. So your teaching site will benefit from what you do and from what others do. Finally, engage. Once you have everything in place, you need people to come. So reach out to the rest of the world using specifically social media. Social media is very powerful to show the rest of the world what you're doing. Keep connected with your alumni. Your residency program is excellent. Before I came here, I requested to see what you were doing, and it's really excellent. So you must be producing every year great people that are the future of the teaching. Keep connected with them. Even if you lose them physically, keep them virtually with you. This will help them grow, and they will help you grow and shine also. Plan your strategy. Any tip you can get and say, okay, let's do this, let's do that, has to be put into a whole plan. So analyze what are your values, what you want to do, who do you want to reach, why do you want to reach them. Make your planning, design for what you planned, develop it, then test it. Test it in-house and test it with your friends before you go global. Then deploy, and then assess the results of what you've done. So, summarizing, plan a complete educational strategy to reach the rest of the world. Think virtual to reach not only the learners in your room, but learners all over the world. Add value to it to be able to stand out of the crowd. Cooperate with others to reach more people, and engage your learners and your alumni. All these things, I think, can contribute to give more visibility to the great institution you already have here. Thank you very much.
Thank you very much, Eduardo. And now with the last presentation of Dr. Rosalind Stevens, it's on her journey from Riyadh to Rwanda and Rosalind's road to global health participation. Yes.
Is this and is this a pointer here? Okay. Thank you.
Thank you, and thank you for inviting us back to the 35th anniversary. We haven't been here since the 25th, so I think your comments about keeping your alumni active and interested are very well placed. I was asked to share my personal perspectives on maintaining an interest in global and international health throughout the course of one's career. We all have many jobs to do, and it's particularly difficult if you work at a university or a private practice to remain interested in something that you originally thought might be a lifestyle you'd like to adapt. So I wanted to share with you some of the pearls that I've discovered since we left Riyadh and now are working in Rwanda. This is a graph I found in Forbes magazine last week, which shows the number of Americans who had passports in 1989. And that's about 3%. We arrived here in 1985 and thought that was pretty normal, but you can see that with such a tiny part of the population, and particularly the ophthalmology teachers being interested in going anywhere outside of the United States, we really were breaking the mold, so to speak. Now the percentage is 42% in 2015, so the world has become global. I remember getting a call from David Payton, who is the physician who recruited me to come to KKESH right out of my years of fellowship. And I think that being able to say yes in that social milieu requires a prepared mindset. Although many of you here are internationally active, I think a lot of you have been born and grown up in Saudi Arabia, so I'm trying to encourage that international perspective because I think that will help KKESH grow and be more prominent, as others have mentioned earlier. My dad was a minister who grew up in Newfoundland, and he had to leave the island. He had to leave Iceberg Alley to go and get his education in Montreal. And my mother grew up in a rural area of West Texas where she had to get on the bus and go out and get her education in the East Coast of the United States. So I think growing up hearing these stories prepares one to make that change. When we did come to KKESH, I will say that was a life-changing decision. My husband was recruited by Dr. Payton, and then I got a call from him saying, do you want to go to Saudi Arabia? I know you'll say no. But with that mindset, of course, I said yes, and we left about 12 weeks later and never looked back. It was really quite thrilling and addictive if you're a well-trained ophthalmologist. You can hardly help yourself. We were here for a 2-year contract, and the following 5 years went very rapidly. Having come from a situation where I thought I'd seen a lot of pathology at Johns Hopkins and at Emory in Atlanta, I thought I'd seen a lot of myopic globes, and you see on the right you're a very myopic globe. But when we got here, it became apparent that almost everybody had myopia, and in the first 2 weeks or so of clinic, we saw a range of pathology that I probably took a year or two in fellowship to see. On the left, you see a giant retinal tear. The optic nerve is hidden behind the retina. And I remember telling the nurses, oh, don't worry, this is extremely rare. So we fixed it by building our own rotating table, as you saw in the lecture this morning. But that year, there were 50 additional giant tears. So the tremendous clinical experience and growth that affords is something that I think you may be taking for granted here, and I'd like to reinforce that. The next is a stage 5 retinopathy of prematurity. People in the United States might see this once or twice a year, and there were 2 or 3 per week in our clinics. Very severe proliferative diabetic retinopathy, I think, still exists here, but certainly in the United States, that level of acuity has diminished markedly. And lastly, retinoblastoma is something that our students even miss on their board exams because they're not used to seeing it. Whereas here, I remember we had this as one of the major questions on the first Arab board exam that we held at KKESH. And I do recall arguing with some of the American examiners who said, oh, well, leukochoria's got to be a cataract. I said, not in our emergency room. What are the advantages of being an expatriate teacher? There are many of those, as I've mentioned. One is the ability to perceive the longitudinal development of skill and judgment in your students. And I can tell you that was reflected yesterday when we had a talk about eye trauma at KKESH. The level of questioning from the fellows was certainly at what I would call an advanced attending level in the United States. And that's really a joy to see. The high acuity of patient pathology here, and the same is true in large eye hospitals in India and China, is something not to be missed for the person who loves their work. Skills maturation, both of the mentee and the mentor is phenomenal. You learn to do surgery meticulously and efficiently, not waste time, and change your technique with every case, which allows a tremendous growth potential for both the student and the teacher. Having been here for 7 years, the ability to see long-term patient follow-up was unusual because we could keep the patients in the hospital at KKESH for several weeks. They'd have their sheep grazing on the lawn, and they were in the hospital long enough to see the complications come up, and then we would refix them as needed, which is particularly helpful in advanced retinal disease. There's a lot of benefit to having the clinical milieu to be able to do clinical research. We had lots of presentations at ARVO, and this is an ROP baby with endogenous endophthalmitis, which is still a very rare phenomenon. Now, what are the disadvantages? It's impractical for most people to just leave town. It's a hard family decision. Sometimes families don't want, the rest of the family is worried about you. You're quite remote from the mainstream medical career. When you're here, you've kind of made a commitment not to be on all the committees that you might have been on in the United States because of the travel. You begin to suffer from what I call the Bill Bryson syndrome. Mr. Bryson is an author who writes about having gone back and forth between the UK and the United States, and he would kind of miss large sections of life. He wouldn't be able to answer questions about what band is popular or what's popular dress because he's missed whole segments of cultural development, and we did find that to be the case here. At about the 5-year point, we came to the conclusion that you kind of have to make a decision. Are you going to leave your expatriate lifestyle, which in a way is kind of free, and go back to a very rule-based environment? And some people do become permanent expatriates, but we elected to go back to the United States because we felt that, number one, there was a war going on. That's one reason we left. And number two, we thought it would be good for our son to re-experience America. Here he is going on retina rounds with me, and now he lives in Shanghai because he thinks that's normal to be living in another country and working as a permanent expatriate. So we went back to the current medical school we work at, Dartmouth-Hitchcock, which is in New Hampshire, about 2 hours from Boston. And at that point, I re-energized myself and decided to definitely be a team player. I quit talking about Saudi Arabia because Americans don't want to hear very much about it. You can show your cases, but in general, your audience is a small one. So I decided to join the bandwagon and did a lot of work for the medical center. I worked as the chairman of ophthalmology for 15 years, Board of Governors, which is an elected position, many, many committees, and I made a lot of money for the medical center because I was doing retina vitreous surgery. All these things stand you in good stead when you need time off. So when I needed time off and was recruited by Orbis International again, I got a paid sabbatical and many weeks off with no arguments, and that is how I was able to maintain this status. After volunteering for several years, I was asked to run the Flying Eye Hospital as medical director, which I've done 4 or 5 times at least and counting. And I think that's primarily because of this experience at KKESH. Orbis, having also been founded by Dr. Payton, knows how important it is to be able to take care of problems and manage faculty from all over the world. So I think that was the strength I brought to Orbis. Now I've been to at least 40 countries. We've had a chance to do many of the things mentioned earlier, such as virtual training, direct training, twinning, and adult education. Also, all of the international projects that came along related to ophthalmology, that participated through the medical school, we joined. We had to learn basic Swahili to do this one on patients with known HIV and TB-positive tuberculin protein, which could then be immunized against the development of further HIV disease in their eyes. The medical school gave me over $50,000 to sign up for a virtual master's degree at Johns Hopkins in international health. And in that situation, I could cope with doing work, making dinner, and doing the homework while online, because all of the lectures are quantified, well organized, and it's really better than being in class with the professor. It doesn't matter what time of day or night it is, you can still do your work. The advantage to me personally was to learn the vocabulary of public health. The public health world doesn't appreciate the retina vocabulary, but if you can learn to speak in horizontal programs, community-based harmonization, et cetera, then everyone is understanding each other and projects move much more smoothly. I also work with Helen Keller International and did several projects on long-term diabetic training in Jakarta and Markasat. Over a 5-year period where you have continued personal contact with your students, you can go from training them how to do something to being quite pleased when they reach the stage where they can do their own treatments and make their treatment decisions independently. One of the things we learn in public health is if you don't measure it, you can't prove that it happened. It's kind of like taxes. So we do pre and post tests on all the individuals. In this situation, we tell them what the questions are going to be before we give the lectures so that they're prepped, and we find that that makes them pick up the main teaching points more easily, showing here that they go from 0% 100 correct to 60% after they've had the lectures. It's also important to reflect on the change in the Orbis policy. This is an organization known for training and surgical care on an operating room based hospital. Now, what we do is only about 15% of the portfolio. In that way, we're now doing 85% on-ground education without using the plane at all. So the current project is to work with the College of Ophthalmology of East and Central and Southern Africa. And this is training the advanced faculty, of which there aren't very many. And this is where KKESH could potentially come in. These 5 countries have only 2 or 3 faculty on average per residency training program. And our goal is to strengthen those residency training programs through developing subspecialty training centers in 4 of them that the other faculty can rotate to and not have to travel on sandwich fellowships directly to the United States or Europe. What we want to do is enhance the structure of the residency training programs by integrating the COEXA adapted ACGME competencies, and we're targeting, as I say, senior faculty. We want them to reach certain milestones at a specified period of time, and this is critical. We find that none of these residencies are training their residents to do complete eye exams. Many of the patients, as you well know, in Saudi Arabia have diabetes, but it's unrecognized. So we want to train them to do indirect ophthalmoscopy and have the mid-level faculty do that consistently. We've been working on this for 3 years, and the infrastructure upgrade is really minimal, providing some basic equipment, but otherwise, as you say, direct hands-on approach, and then discussing patients directly in a learning situation is much easier than a teaching situation. We also work on biomedical engineer training, supply chain management, rotate the faculty, and expect that these subspecialty training centers will be established in Moshi at KCMC in pediatric ophthalmology, in glaucoma at the University of Nairobi, in manual small incision cataract surgery in Mbarara, this is northern Uganda, and at the University of Malawi at the Lions Eyesight First Hospital. Although I mentioned that this project takes place in Rwanda, we're actually having the 3rd week of training in Malawi because they have a huge patient base with a 1,000-bed hospital, 95 beds of which are devoted to ophthalmology. So in the picture on your right, those are the chairman of the department from Malawi and representative students from Uganda, Kenya, and Tanzania, as well as Western Kenya. So medical education is worthwhile. It's sustainable for the long term. You have an opportunity to use your skills and enhance your own lifelong learning. It's extremely rewarding. And that's why you should be interested, but why should KKESH be involved? So in summary, I'd like to say this is one of the largest eye hospitals in the world. When we started here, it certainly was the largest in terms of bed numbers. The health systems are already in place and functional. You should appreciate your biomedical engineering, your imaging work, your pharmacy, and particularly your ophthalmic tech training. We have very well-trained, highly motivated subspecialists here. And I think that the knowledge that they have, the judgment, the clinical judgment they have is something not to be wasted. It's a very precious item to be able to pass on to some of these countries that are not so far away and certainly would benefit from your help. Thank you very much.
Thank you, Dr. Rosalind. The last presentation is by Dr. Adel Rashid, who's very well known by all of you for his extensive work internationally in delivering eye care in many areas and many countries of the world. Dr. Adel. Dr. Adel is going to be brief, inshallah, and he will focus only on, based on his experience, what should we do and not do when you do eye care international and outside the kingdom.
Shukran Abdulaziz. Good afternoon. You know, it's the last session or the last presentation in this last session. So if you would bear with me, I'll try to be brief and hoping that the message will be received. Okay. The topic I was asked to deliver is does and don't in international outreach. In another word, what should we and should not do when we think about international outreach eye care programs? The information I'm going to deliver based on our experience in Al-Basr International Foundation, which is a non-government organization working in the field of prevention of blindness for the last 29 years. BIF has and runs 29 base eye hospitals in Asia and Africa, and has conducted so far more than 1,460 outreach eye services. And it has 3 human resource development centers in Asia and Africa. It covers 45 countries on its outreach program. I will share with you 10 does and don't when we talk about or when we think about international outreach. The first one, in human resource development, it is very essential. Whether we are talking about technical, administrative, supportive, and we experience, as well as the other, that some programs are on hold or canceled due to failure to obtain human resources. Number 2, leadership development and strategic planning. Despite we all know that leadership is an inborn gift, but someone has to take the lead. Leadership and development, or leadership development and strategic planning, can be aroused by holding seminars and workshops, involve the experts in the field, on-hand trainings, and rotate the key personnel between different centers. Third, social marketing and demand generation. We all agree that the need is there, but the demand is to be generated, whether we are talking about decision makers or we are talking about end user. Service delivery and operation management. We are talking about crowd management, delivering the eye care to mass population. We should not ignore or forget the quality of work that is delivered. So, we are looking for patient satisfaction, at the same time looking for quality assurance of the work delivered. Now, the work that we are aiming at when we talk about outreach should be exposed to core financial concepts, which means either we are talking about charity, non-government development organization, or we are talking about a commercial one. In the first instance, it has to be self-sustained, because donors, as we all know, will not continue supporting or will not support as the same spirit that they start the work with. In the commercial side, we have to be sure that it is cost effective. Now, whatever we do, it has to be monitored, and we have to develop information system, and this is to be shared from within or by the others stakeholders in the field. One of the important points that we should look at, especially when we are talking about outreach program, is how do we manage our employee, how to keep them. Despite that, we like this, that I am the boss. It should not be our aim that everybody is quiet, because you will come one day and you are losing one of the key figures of your employee. If we can create a team work, this will help a lot. And if we can make our workers enjoying their work, this will help a lot. Number 9, we should design a comprehensive eye care services that reflect the community needs. This has been enlightened by Dr. Rao and Dr. Babar Qurashi, starting from the community down, which will treat, and before that detect and refer to primary health centers, and from there to district comprehensive eye care program, which will provide primary and secondary healthcare complex services. And there we have the tertiary. From there we go to the tertiary eye care, then to the center of excellence, where it will take care of the human resource development. The 10th point that I will share with you is we have to establish partnership with major stakeholders so we can complement the work of each other. When we talk, ladies and gentlemen, when we talk about outreach, we aim addressing the problem of a huge number with a good quality, a sustainable work that also takes care of human resource development, and not compromising, as I said, the quality. Was it or is it an easy task? It is a long way. And sometimes we go off track. And sometimes we had to use whatever available means and ways. These are old pictures of myself and a colleague, you know. This is me riding a horse, and in the bottom to the right, this is Akif al-Maghrabi and myself riding donkeys in one of the field work. But I assure you, by the end of the day, the achievements are great. And the smile is just right. Let me leave with some take-home messages. We have to be very careful when we conduct this outreach work. People there, whatever you say, this is like a promise. And they will ask you every time they see you what happened to something which you don't even recall. So the golden rule, under promise and over deliver. We should avoid this sort of situation, that we put a lot of planning, we have a human resource manager and we have a marketing manager, etc., and only one person who is executing the work. Again, something which I differ with some of the people here, we have to look at practicality versus idealism. When you are faced with a number of 500 and 600 surgeries, and it has to finish within 3 to 4 days, and you have to meet the quality assurance about how you conduct surgery, sometimes you are finding yourself that you are operating 5 tables in one room. Again, be careful not to be labeled as a second-class medicine deliverer. One time, unfortunately, we had a bunch of expired medicine in one of the outreach programs, and it was discovered, and we were tagged as people who are delivering a second-class medicine. And to get rid of this image, it took us a lot of effort. Just a small mistake by one of the technicians. Let us look at training versus service delivery. Both are needed. And sustainability versus crush programs, we have to weigh between the two. And we have also to be careful not to look for an influential local host and forgetting the practical local host, because we all need local hosts when we talk about outreach. Ladies and gentlemen, in outreach, we are not targeting elderly. We also have to be careful about the young individuals. As a conclusion, we are looking for a productive individual like this. And seeing kids like these, and thankful patients like those, and finally, a big smile like these. Thank you very much.
Can I ask all the speakers, please, to come to the stage? And while they're coming up, I'll just have a few house announcements. We have a station for free flu vaccines in the exhibition area. So, it's a flu season. Anyone who's interested, you can just go there. They'll have your vitals taken and they'll give you the shot. Quick, painless, and very effective, I hope. Second, we will have a discussion, some workshops that will take place on Friday morning from 8:30 to around 11:15. And between 10:15 to 11:15, we will have a plenary. The first discussions will be within groups as a workshop, and we'll discuss several items and matters that relate to training and education. And there will be a plenary session from 10:15 to 11:15, correctly back, where all of you are invited to come. It will be interesting because all the groups will present their recommendations on how to improve on education, on training, on patient care, outreach programs, whether local outreach or international outreach, and the development of organizations. So please join us at 10:30 for the discussions. There will be a dinner. We intentionally left tonight's evening free for those of you who want to meet with friends, go for dinners, or coffee, whatever. So we did not put any social activities. However, on Friday night, there will be dinner at the KKESH compound. I guess on Friday afternoon, we'll have more details and the transportation arrangement and everything else. Let's hope the weather will still be great and it won't rain, but if it rains, we have a big tent. So, and the food there will be local food, traditional food, so it's a different experience. There were some requests for shawarmas, so we'll have fresh shawarmas served, and there will be a lot of fun and entertainment and some old memories that will be discussed and some quizzes to see which one of you still has a very strong memory and remembers the names and faces and recognizes the bold back images of some of our consultants. Okay, thank you very much for all the panelists and speakers, and we open the floor for questions. Any questions? Okay, I'll start with one. Eduardo, you've mentioned on how to improve on the quality and the other means that are available for education. And these are excellent. However, in our country and in our region, the case is a bit different. Our access to information is we're privileged in many ways that our access to information is relatively easier. Our system does not really recognize online learning in reality. Very few online courses are recognized by our Saudi Commission for Health Specialties. So even if our residents go online and take some of these courses, they're not really recognized. How can we get them interested in such activities? Yeah, it's working. Yeah.
Okay. Well, the thing is, if there is a regulation by your board that CME cannot be gotten online, the only way to to change that is to change the regulation. But all my talk was not really thinking on your residents. All my talk was thinking on sharing the way you teach your residents and the way you develop CME to the rest of the world. So it's not about having your residents doing this and getting credits for this. Tomorrow I will be talking about the flipped classroom, and this is a way, I think you're already using this kind of thing, but this is the way your residents also will use e-learning to learn. But regarding, all my talk was about projecting what you do outside, to shine outside, to reach others with the way you teach, developing good interventions that would benefit residences all over the world, and doctors that work daily also to develop their skills and their knowledge. And in their countries, most of the countries recognize online CME, and that has value for them.
We actually have that. The problem is, as Dr. Babar says, we are not very good at promoting ourselves. We have a grand rounds that is every Tuesday, where all the lectures are put online, are available online for anyone to see. So if you log on to our KKESH channel, all the presentations that are presented during grand rounds and sometimes even subspecialty, and when we have visiting professors, are all projected and all available online. We had a project several years ago with Kaduna University in Nigeria, where we had a direct link with them in terms of the grand rounds and the subspecialty lectures, and their residents could actually interact with our presenters. We also have our own channel on YouTube where we put surgeries done by our consultants as well as lectures. So we have lectures, surgical procedures, educational programs. But as you said, very few outside the region know about the availability of, and this is all, of course, free of charge. But very few people know about it. You're absolutely right. Dr. Rao, how can you convince a donor to give you your money, or his money, sorry? What are the, how do you go and convince him and tell him that I will really use your money effectively and efficiently? What strategies do you use to convince them to donate to you?
I think the most important thing is the credibility of the organization, and then the credibility of the individual that is asking for it, on top of the proposal that you are submitting, the idea that you are submitting, for which you are seeking support. For many years, I used to think that in the West, people fund the programs based on the quality of the programs. But I was surprised a few years ago, Al Summer was telling me that during his time as Dean of the Johns Hopkins School, he mobilized over $500 million. So I said, Al, you get all this money because of the reputation of Johns Hopkins and the programs you have. He looked at me and said, yes, that is there, but remember, people give to people. People don't give to projects.
People don't give?
Don't give to projects alone.
To projects.
They count more on the credibility of the individuals.
Great. And then how do you convince donors to give you money on basic research, on structural support for building, institutions, for building? Because from my experience, donors would like to see the effect of their donation immediately on patient care. They would not pay for staff. They would not like to pay for research. They would like to pay for people having cataract and seeing post-op.
That's very much common in the philanthropic culture of the developing countries, where most of the people want to give for service, where there is an immediate impact that you could see. But very few, in my experience, even in India, the first money comes for service. Second comes for supporting education. Research, very few people go for it. But even within that, they only support 90% of the time the capital cost. Hardly anybody would like to support the operating cost. So without question, I think in our countries, it's service, education, and research the least. Research will be supported by only those people who came from a research background and built organizations afterwards and became very wealthy. Those who are not like that, very, very unlikely to support research.
Okay. Any questions from the audience? Dr. Deepak?
So I have a question for both Babar and Nag, maybe related to the different layers of care that you propose or that's followed: primary care, secondary care, and a center of excellence. So most often the care comes from top down, right? You have a center of excellence that drives the development of secondary care and primary care. So in a system where you have excellent tertiary care and then you're developing primary care at the bottom, how do you prevent, or do you face a problem where secondary care systems are clogged and that people sort of drift into the tertiary care systems where because the secondary care systems are not well developed?
Thank you, Deepak. Normally what used to happen, and still happens in many countries of the region, is you have well-developed primary care, and then you have centers of excellence, a tertiary eye care that is developed. And people began to bypass secondary eye care. And therefore, all your tertiary institutions ended up doing hundreds and thousands of cataract surgeries and not doing teaching, training, research, and subspecialty development. I think that is something that has been found more and more, the gap in the whole eye care system. And we now recognize that secondary eye care is the backbone of any country's eye care service delivery. So primary and secondary go together so that 80% of the needs are met, and only few percent then goes higher to the tertiary and the centers of excellence. So that's the way the flow of patients would work.
Any other questions?
The eye experience, how have you dealt with this issue?
I think I echo what Babar has said, but what we did was being very careful. We started with our center of excellence. At that time, it was only at the tertiary center that we started. And with years of experience, having seen people coming from rural areas treated at eye camps having very bad outcomes, we decided that we should create a model for secondary level rural centers. So the second thing we did was secondary rural centers. And after that, we did primary. People ask me, top down is bad, bottom up is good. I ask them this question. Suppose 30 years ago, if I started with a primary care vision center, where would LVP be today? Because of the power of the center of excellence and the clout it enjoyed, we could create this whole network and the system very quickly, which made it very effective. If I started with a primary center, I probably would have made another 10 primary centers. That would have been the end of it. And primary centers in isolation don't continue. They cannot, they languish. They have to be linked to a system. And as Babar said, secondary centers are the backbones of service. That's why in the pyramid that I have shown, we deliberately call the secondary level center as the service center, as a kind of a generic name. But it could be government sector, private sector. It could be equal to a single practitioner's practice to a service center. So unless secondary centers are promoted, as he rightly said, tertiary centers will be flooded with secondary care, and that reflects on the teaching in those tertiary centers. That's why most of the teaching programs in developing countries have become extremely poor.
Baba?
So going back slightly to the donor and the donations, I think there are two types of donors. One are the private donors and one are institutional donors. I'm beginning to see more and more institutional donors beginning to recognize the fact that systems need strengthening. And the systems actually need infrastructure, need human resource, need management, need equipment. So I do see that change happening at the institution level. So the DFIDs, the USAIDs, the Irish Aids, these kind of big institutions are beginning to recognize that. But an individual donor, I completely agree with Nag, still focuses on a cataract surgery plus cataract surgery.
Thank you. Dr. Hassan?
I would like to thank you all for your great experience that you transformed it to us and give it to us. My questions to Dr. Adil regarding to the charity works and the tips that you have. I think you start from scratch and build up with experience day by day. Here in Saudi Arabia, we have a lot of graduate, but during their, postgraduate, they are not exposed to this part, which I would like to implant that from early stages of their training postgraduate to be incorporate in these charities, not just only outside, even so internally to build these camps, even locally in our country or even in the surrounding countries. Is it a way there to get implant that?
Well, we do have active participation of some of the residents as well as the consultants from King Saud. And who's taking the lead is Adil al-Shibani. We do also have participation from other universities. It is less than what it should be, but there is a scheme to accommodate. But most of the time, it's better for them to be accommodated with the hospitals rather than the outreach programs. Outreach, they will not be able to, we don't want them to go there because they might be left behind because the surgeon there, they are very fast. They finish 100 to 120 surgeries a day. Usually we design one bed and allocate one bed for those sort of visitors or volunteers. Then, sometimes they catch, sometimes they don't catch. But invitation is open, if I understood you well.
So, Dr. Adil, how do you respond to people who tell you, let's say KKESH wants to branch outside and be involved in some of these ophthalmic educational and service deliveries outside the kingdom? There will always be people telling us, focus first nationally. There are lots of needs in the country. Why would you go outside? Fix this first and then go international. What would be your answer?
Well, my answer is there is a place for each, because I am faced with this question and inquiry every time I approach donors. Every time I approach officials, said, "Ya akhi, al-aqrabuna awla bil-ma'ruf." Those who are nearer to you, they deserve more attention than those who are far. I always respond that, there is a place for this, and there is a place of this for this. It's complementary and not contradicting. There are many things that we could do outside which we cannot do inside, and vice versa.
Like what?
For instance, when you talk about a cataract that will cost less than $100, a phaco with foldable IOL, this doesn't apply to a cataract or a phaco inside. So if a donor will give just $100, he might have sponsored 1 or 2 surgeries. But if he wants to sponsor a surgery here, he has to give maybe $2,000. This is for just as an example. Also the amount of work that conducted, and you have seen what is happening in one of the hospitals in Sudan, that a huge rush of patients trying to address their problem, and this could not be done in a system which is built over here. We have a system here, going back to the question of donation. If you could get fatwa that the work you are doing, a declaration from the health authorities that the work you are doing could be sponsored by zakat money, many people they will give.
I think there is something like this.
There is, we have it. This does not apply to inside. Many people they will tell you, يا أخي الحكومة أبخص. They will say like this.
So the government is supposed to take care of. The government is supposed to take care of.
The government is going to support, but those who are outside, nobody is supporting them. So you'll get a huge amount of money, which people they will refuse to spend it here because of this thing. Also, if you get some sort of recommendation from whether you are talking about religious authorities, leaders in the country, that if they give you a recommendation, tazkiyah, this can help a lot in finding donors or in hunting donors. But I have to make it clear that here there are a lot of sort of regulation and things that you have to follow as rule and regulations when it comes to donation collection.
Okay. Dr. Rosalind, you had an extensive experience in many developing countries, and have done so much work and donated so much of your time to help others. And I'm sure that came at the cost of your own time, your own income, and so many other sacrifices that you had to do. What would you say to people to encourage them to give out to others who are in need? How would you encourage them to do that?
Well, I think it's a rule of humanity that you get more when you give. And we are very privileged to have the wonderful education that we have. All of us have had the support of society to be probably some of the most well-trained people who have ever lived in our generation, whether you're in the United States or India or China. People that are at this meeting and similar meetings have, I think, a debt to pay. Because of what society has given us, we give back, and when we give back, whether we think we're building our karma or going to nirvana, or I think just the joy of seeing people do something well technically and seeing the result when they treat the patient and feel good about it is enough.
Okay, thank you very much. If we would say that KKESH is going to embark on a new but a new role, and that KKESH is going to go internationally to help other countries and centers of need. To the audience, what do you think should the main function of KKESH be? Should we focus on education, providing electronic or distant education and training? Should we send people there to give lectures and surgical skill transfer? Should we go and do procedures over a period of 2 weeks, like the eye camps, and do as many as we can while still training some of the local doctors? Which one of these three activities is probably strongest at KKESH and will have a major impact? Any ideas? Dr. Travelsi?
Yeah.
I'm sorry I didn't see you, but we'll have trouble seeing.
I just wanted to say something because I learned from Rosalind, but one of the things I would remind you of is Live Aid. And the food that was, all the people donated millions of dollars, and the food rotted in the docks. The people in Ethiopia never got the care. So don't waste your efforts in places that politically, I don't understand how you got into Rwanda. I don't understand how you got into Rwanda, because we tried to do Sudan. But the biggest thing I would say is to continue, keep going back to the same place. That you don't just do a one-spot Band-Aid. That was the difference with Live Aid.
Dr. Ahmed?
Thank you. I'll talk from our experience. We do a lot of campaigns in West Africa. It started actually by campaigns. We usually do about 4 microscopes working by our surgeons, and the 5th one is for the hosts to pick up the surgical technique. And then we make sure that he actually adopted the technique. And later on, we get them back to Tunis to be exposed for higher or better quality of work. And this is what we call sandwich program. My feeling that KKESH has both modalities actually. You can do both because hands-on training is a bit difficult in foreign countries like ours. I mean, you cannot get any foreigner doing any surgery in your country. So the best thing is to go there, give them the technology, and then inviting them back to consolidate what you've done for them. So this is what we call sandwich programs.
Thank you. Any thoughts from KKESH staff, previous KKESH staff? What should we do? Okay, I'll ask you one thing. You said all of them, Hassan. Which one is the priority? Focusing on distant electronic learning, sending someone there for a week or 2 weeks to train the staff and the physicians over there on certain procedures and giving lectures and training, or sending a group of doctors to perform surgeries while at the same time training doctors? Which one of these 3 you think is a priority? So who thinks number 1, distant learning is the priority? Okay, who thinks number 2, sending someone to stay there over a week or 2 to train local physicians? And who thinks we should send campaigns to do surgical procedures? Interesting.
Well
The
trained.
panel, what do you think?
Can I comment on?
Yeah.
Actually, we are doing another one. We are doing a completely different one.
Okay.
We have gone into Liberia now. We are developing a complete eye health system for the country, and we don't go anywhere else. Just that country, focus. First, we started the ophthalmology department in their main hospital in the capital city. 6 months ago, we started the residency training there for the Liberian doctors. Now we are going to start technician training. Then 8 months to 9 months from now, we are starting our first primary care vision center to be spread out through the rest of the country. Then develop another 2-3 secondary centers. Create a system for the whole country.
So you're saying focus on one country
You go to
and
one,
devote all your
adopt
resources.
one country, focus, and create a replica of KKESH.
Great. Any ideas on how KKESH should get involved in international outreach, other than what NAG suggested?
I think having the opportunity to have people come here and train, whether they're biomedical engineers, say for a 6-week program. This is a bit the way Aravind is structured. We have many people going via Orbis to be trained in Bangladesh and Chittagong and in Aravind because they're welcoming, and the people can leave their practice for 4 to 6 weeks and survive, practically speaking. So I think a pizza pie selection of things that could be trained and tuned up to the point that there's some hands-on work, and then perhaps their mentor goes back and checks later to provide support.
Okay, great. Tafadhal, last question or comment? I'm taking advantage of this. Is the last
If we
session.
combine the thoughts which we have heard now, I think we can initiate like a campaign to implement what Dr. Rao has just said. Like KKESH and other well-known hospitals all over the world. If each one of them is taking one country, a needy country, and focus on that country, I think this will be a great achievement. And I think this is an ethical commitment. They are deprived and we are privileged. And this is our way to thank Allah subhanahu wa ta'ala for being privileged for that.
Thank you very much. And with that, we conclude this session. Thank
Aziz,
you for
Aziz,
attending.
I want one comment on the sacrifice you said, doctors.
Yeah.
A few months ago, I ran into a high court judge of ours at an airport, and he told me, Dr. Rao, you are getting wealthier and wealthier each day, he told me.
Who's getting wealthier?
A high court judge.
Okay.
So I was taken aback with that statement, whether there were any rumors floating about me or whatever. So then I said, what are you saying? He said, you know, I don't know whether you ever think about it. Every morning, when they open their eyes, how many hundreds of thousands of people must be showering blessings on you? What form of wealth can be better than that?
That's true. Thank you. And with that, we conclude. We'll see you tomorrow. The general session starts at Dr. Sousan 1:30, 1:15 on Friday. So we start at 1:15 on Friday. However, any one of you who's interested in listening to the discussions and the recommendation out of the workshops, it will be from 10:15 to 11:15. Jum'ah prayer is very close by. We have a mosque that is close by, which we can all go to and then come back for lunch and attend the dinners, the activities. I hope we can see you all tomorrow. Good luck and thank you. Thank you, guys.